Oh, Check 1, 2. Just use that. You're good. I think you're good. This is
Perfect.
still on mute.
Perfect. But yeah, so kind of in relationship building and thinking about medicine, always kind of having this approach to the care we're providing, always collaborative, looking forward on the same path, but always self-determination and autonomy for Indigenous people. I mean, and then when we talk about Indigenous health particularly, I think we all kind of know about the large health inequities Indigenous people face. I don't want to kind of belabor this point. This is from a recent Lancet article talking about high rates of tuberculosis, high rates of diabetes, more rates of food insecurity, lack of housing, worsening things when it comes to life expectancy, infant mortality. And I think a lot of us know these stats. What about in healthcare? Like, what about in the patients we directly deal with? So coming from a GIM world, we particularly deal with post-op patients, common consult we receive. And here's a recent systematic review of 28 studies from 4 years ago in 2021, looking at Indigenous populations post-operative outcomes. And it shows that they have 30% higher rates of death following surgery. So even in our populations that we see every day, we know there are worse outcomes. Here's another recent study from CMHA in 2023, looking in Western Canada at kind of Indigenous females compared to non-Indigenous females during pregnancy. Again, looking at healthcare results and having higher like mortality and worse outcomes. And this is recent from populations, again, we deal with. So it's not looking at the overall picture, but here in healthcare, we know Indigenous people face worse outcomes and face systemic racism. When we look at Six Nations, like in our backyard, this is considered one of the wealthier reserves in Canada. They have a lot more money. They're a lot closer to tertiary centers throughout the nation, and we can still see differences in health outcomes. So when we look at the number of chronic conditions, what usually directly correlates to worsening care, we know that Six Nations people have higher rates of chronic conditions. We know they have higher suicide and addiction rates. And then kind of with those chronic conditions, we know they have less healthcare, less access to healthcare, which is very evident when you work out there, and they have higher unmet healthcare needs. Now, what are the barriers to improving health? Because we have to think about the barriers if we kind of want to move forward. Anyone want to name any? You can probably name like 30, but.
Lack of trust.
Okay, very big one. And we see it all the time on the reserve when we go and treat patients. When we ask them if they want to come to Firestone to get a PFT, I would probably say half of them say no because they don't want to go into a Western hospital.
It's like a misalignment between Western views of treatment versus Indigenous and Indigenous cultural views of how things are treated.
For sure. Often practitioners, if a patient talks about traditional medicine, rather than kind of empathizing them or understanding it, they'll shut it down and talk about its deleterious effects or why it's bad for them, such as smoking tobacco, which is very common in Indigenous populations. As respirologists, we may frown upon this. Yeah. For sure. We have patients who, if they want to come to Hamilton, for them, that's a long drive. They're often like the main supporter of their family. They have to take the day off. I work in Northern Canada where Indigenous populations, if they want to go to a health center, you have to get on a 4-hour plane. So what else?
And currently in Ashwikan, there's only one medical transport driver. There's no public access to public transport. And that medical transport is often overbooked. So they have to wait for their turn to actually get into the city.
What else?
Lack of shared background to the intent. So that our backgrounds are very different. Our education systems are very different.
Yep.
All the learn are very different.
Yeah.
And you talk about cultural norms about acceptance of smoking, but there are plenty of other norms that we accept as usual to get adult blood, which would have been different for people who grew up in the Six Nations. One of the things you said earlier on at the beginning was the importance of developing a shared something. We're starting from different worlds. So that,
yeah,
there's plenty of steps in between where we're starting from and that idea of being in a shared decision making. We're miles.
For sure. I think you point out multiple. I mean, one, they talk about education and poor health literacy, but also the latter point of just a fragmented health system, right? Like they up north, if I care for a patient, it revolves 4 different EMRs. That doesn't provide good care to anyone. Here, there's no tertiary center on Ashwikan. Patients either go to Brantford, or sometimes they'll come to Hamilton. We don't have connection to each other's notes. It's a lot of fragmented care that leads to poorer care. Anything else? So we want, sorry? For sure, right? It's not your top priority if you're just trying to live to go and get your x-ray. Yeah, and along with social determinants of health, that comes with like lack of access to healthy food. So if you are up north, there's one grocery store on a reserve. The grocery store is owned by Hudson Bay Company, which can put whatever price they want on anything. Essentially, that means all your prices are raised for whatever food you want to buy from your one grocery store. With that goes lack of housing. So most of the reserves, you have 8 to 10 people living in one house. If you don't get supplies to build further houses, it gets more crowded. So definitely social determinants of health. And I think we can kind of click through all of these and kind of recognize how they contribute to how they're barriers to improving Indigenous health. Another few I want to point out is loss of on-the-land learning. So this is a very important topic in Indigenous health, where we kind of look at ourselves as doing our best on the land, whether that's for like our spiritual well-being, our physical well-being, and just the taking away of land and kind of areas to practice this contributes to worsening Indigenous health. Another one I wanted to point out that I often find interesting is language barriers. Because we're multicultural here. We deal with multiple people, like people who speak multiple language. Translation systems here don't particularly have Indigenous languages like Cree on them. And I've actually had patients who've been declined procedures because they weren't able to give consent just because they spoke Ojibwe or Cree. They said, oh, they can't speak English, they can't give consent, and they were declined a coronary cath. So it's a form of systemic racism that we don't think about that is apparent here and across Canada. Another intergenerational trauma. And this is kind of leading into the second part of the review, where when we think of Indigenous populations, we often think of like a weakness perspective, right? So a kind of a deficits-based approach. So what are the deficiencies? What are the problems? All the things we just discussed, like how can we help these people that need our help? What interventions can be done? And it doesn't really align with Indigenous ways of thinking, which is a strength-based approach. A strength-based approach is kind of what does our community have? What do we bring to the table? What have we gone through? What makes us stronger? How do we move forward from here? This is often how Indigenous communities think of ourselves. We've been through residential schools, we've been through generations of trauma, and we are resilient, and we are a strong community. And it's about kind of turning that weakness-based approach to a strength-based approach and acting, how do we move forward from this? And this is kind of the meaning behind our internal medicine clinic, is kind of, what does this community have? They have, when you go there, everyone knows everyone. Everyone in our clinic is family with each other. Everyone is like very kind of communal, is strong, we look out for each other, and kind of bringing our clinic in with that point of view. A clinical example of a strength-based perspective would be someone who's hearing voices. In a Western sense, we would label that schizophrenia, move on with our day. In an Indigenous sense, that could be kind of looked at as a knowledge keeper, or someone who's hearing voices from the ancestors. And that's something that these communities would be proud of, which is very different from how we would label it in Western medicine. And it's kind of reframing these kind of ideas and putting them in Indigenous perspective that led to the creation of our internal medicine clinic on Six Nations. So we identified kind of this need for specialist care, but wanting to work with community, and that they have this high burden of chronic medical disease. And us as internists, we deal particularly with chronic medical conditions and kind of providing long-term care and providing further access to subspecialists. So working with the Six Nations Health Authority or Health Services, kind of creating an internal medicine clinic in kind of the spirit of the Wampum Belt. So working collaboratively on one path forward, but allowing Six Nations to kind of retain their autonomy, to kind of have control over this clinic, while we're there to kind of build them up, and kind of led into our internal medicine clinic, which Zahira will now talk about and kind of take it from here.
So thanks, Dr. So from the internal medicine rapid assessment clinic, just to give a background in terms of the infrastructure where we started and then when we went, the clinic was I'm not gonna, no one will see me, but
I'll do
I'm still there. So the clinic was essentially in Six Nations. There are two health buildings, the Ganios Center and the White Pines Wellness Center. White Pines Wellness Center has a part of it which just leads to the dialysis center at St. Joe, which is how we started collaborating with the Six Nations Health Services. So the goal, and initially when they had asked us to, we were only hoping to have a long-term clinic for Curtis, and it kind of evolved into this clinic that we want specialty care on the reserve because of access to care for many reasons. Initially, they have been to Brantford, and I'm looking at Jess, so they have been providing care at DAHAC in Brantford, and so we started off with having a vision, which was Jennifer Smith, the executive director of Six Nations Health Services from our family health team, to provide specialty care, especially with patients who are coming out of emerge, being discharged from the hospital, and actually having not waiting, months and months to see a specialist, and if could we do that. And so we had, we kind of were doing that with our CIMRAC and IMRAC models. So we kind of combined what our IMRAC and CIMRAC do. And for people, like I'm seeing some faces that I don't recognize. So our rapid assessment clinic in GIM, they essentially work with getting patients from ER or other specialists that need to be seen rapidly and be worked up. We don't follow them very, very longitudinally. We kind of provide them as a bridge. If they don't have family physicians or if they are at high risk of being readmitted to the hospital. And that's what our clinic has been doing. So we kind of put that same model. We initially did that at Ganio Center, which at some point in history was actually a hospital in Auschwitz, and it's not now. But it actually had 5 rooms for us, a procedure room, and we had lots of hopes for it, but it closed down in somewhere this last year, and we were moved to White Pines, where we are sharing a room now with the primary care practice, and are down to 1 room. And so that's important in how we actually, in this discussion, evolved. But the clinic itself has actually, which we thought would not be busy, it's actually very, very, very busy. So just in terms of our models, as we discussed, we combined the model of CIMRAC and IMRAC. And we kind of had this, we use these slides that you have to actually go to all our stakeholders within the community. So we were essentially not only going to serve the Haudenosaunee people that were on the reserve, but also anyone who identified as Indigenous and lived near the community. So they didn't have to be on the reserve, but outside as well. So that includes Niagara Falls, St. Catharines, Hamilton. We actually learned that people at the DAHAC clinic, which is the Indigenous clinic in Hamilton, they actually have patients coming sometimes from Simcoe, Timmins, to actually see someone because they want to be near their specialist, or they only want to be seen at a clinic that would value their Indigenous traditions. So we wanted to kind of make sure that the clinic was open to anyone, and we have actually gotten patients from all over. So we kind of had the same kind of patients. There wasn't a lot of knowledge on what GIM is, so we spent a lot of time letting family physicians, nurse practitioners, local home and community care understand what GIM was and what we would be able to offer. We essentially had as a collaboration. So again, the concept that Curtis mentioned about the wampum belt has actually been very core to how we have had any of our stakeholder discussions to actually, that actually comes up a lot with any discussion. Anytime you open a new partnership, that you will be respecting the wampum belt. That was actually one of the first things I was handed as a wampum belt, which is a big privilege to actually understand that we are 2 canoes and you will respect our autonomy and we will respect where you're coming from. And that has been the basis of all our memorandum of understanding as well as our collaboration. So, and the right to self-determination, which Curtis mentioned, is actually very important. So our clinic is one of the clinics where a patient can self-refer. They don't need a family doctor. They do not need a nurse practitioner. They can actually say, I want to be seen by an internist, and we will schedule them in. You would think that would actually create an issue. We've actually, all those self-referrals have actually been very legitimate. Very sick patients, not somehow lost to follow-up, because we are not only having patients from Brantford and Hamilton, but also people who might have been getting care in the US and now not going there. So we actually sometimes have discharges from Buffalo or other hospitals who we have had to transition to care over here as well. So I don't, and home and community care. So home nurse, if she's worried, paramedics, if they are worried, they will actually, so our paramedics, home and community care, referrals are all our sources of referrals. And I would say it's 50-50 right now between family physicians and nurse practitioners referring and self-referrals from the community that we also get. Even a dietitian, if she has gone and was helping someone with their food intake, or would actually say, I don't think this patient looks well. I think they shouldn't be going to a walk-in clinic. Can you come and see them?
And it brings us closer to our patient population, which is quite nice. It is a bit frustrating. Sometimes you'll get a referral and the referral will be like from someone's mother, and we'll say patient is, or they're sick. I mean, are like, oh, what does this mean? But it's about the community. They all know each other. They're all very entwined in each other's lives. And the fact that they are trusting Zahira and I, who are not from community, and taking the time to see us, it's very important. And it allows us to kind of get closer to our patient population. It's more patient-centered care, I would feel.
Yeah, and so, and even, so even if we are seeing referrals that maybe, patient is fresh post-op, we may be able to navigate things for them. So it's been a lot of advocacy and building trust. So in terms of the infrastructure that we had, so we had our admin, we shared between St. Joe's and the Six Nation Health Services Family Health Team admin. They were responsible for booking the patients. Because of ownership of data, there has been still an issue of who owns the patient data. So we have Dovetail, where all the patient information is stored, and then there's EMR or PS suites on Six Nations Family Health Team, and the data is all stored there as well. So there's a lot of duplication on data, and we're still trying to figure out how we can navigate that system. So and this is the same for the dialysis clinic. Dialysis clinic also duplicates the data on the two EMR systems. We have had and what we have done, so we built a GM clinic first, got patients starting there, and then our hope was to kind of expand that to other specialties. So this was essentially how the clinic was there, that referrals would be first received. So every Tuesday, Curtis and I will triage all the referrals. We will see where the patients will be booked in GIM. We usually, because of the billing system, and our specialists who will only be seeing a few patients, we would actually refer the patient to them. So at that office comes that, if I'm going to come here as a specialist and only see 3 or 4 patients and I'm getting all of them self-referrals, I cannot bill a consult. So we made that everything would be going through IMRAC. So one, as general internists, we could do the initial workup, make sure that it's properly worked up for the specialist, and then review it with the specialist. And we have had Josh, Kieran, and Jane help us with some of the patients from RESP as well. So just kind of, can you do a virtual consult with us? Can you guide us with what we need to do with the patient, and then navigate them through Firestone as needed? We have had e-consults as well. So we did set things up with e-Ontario, where we can receive Indigenous based referrals from any of the communities that would want to have care received from this thing. And patients can refuse as well. So we have had a lot of patients who have been referred by their nurse or their home care nurse or their paramedics to go to our clinic. And they said, I do not want to go in a clinic where everyone knows everybody. So it's the other way it works around as well, where we have had a lot of patients. So again, the right to self-determination, we don't, essentially, we put a lot of emphasis on consent as well. We've also had requests to go into Brantford General or St. Joe's if it's a patient that Curtis and I have seen, and the patients have requested for us to be there to actually translate medical information for them, or actually convey to them what it means to kind of, again, for that trust building of collaboration. We have had good success in discharging patients over to care. The family health team has been amazing because they've really, so speaking of strengths, the family health team, the paramedics, and the home and community care really work as a tight. I think it, we in Hamilton could actually learn for how well the community actually works with each other. Because when I have to transfer a patient who's doesn't have a primary care provider or is a recurrent visitor to ER, paramedics work very closely to actually provide ongoing care, daily checks, ensuring that medications can be given or bridge the gap between ER. We've actually had to resuscitate someone in the house with the paramedic, and then decide this is not actually going to be, this is going to be futile, and actually provided palliation with home and community care transition. The patient never left their house. So we actually had a full aspiration sepsis event, and we actually did that. The patient did not want to go to the hospital, but we provided them good quality of care within the house, which actually has become a norm. We thought it would be a one-off. So we started collaborating with the palliative care outreach team over there as well. So the scenarios that happen is that if a patient needs to go to ER, we actually ask the paramedics and stuff if there's something that we can intervene on. Curtis and I, if we are there, we will actually discuss, walk them through it, and try to avoid ER. We have, I think, since we have joined, we've only had to actually send 2 patients to by ambulance to ER to get admitted. Otherwise, we have been able to prevent ER admissions both by family health team as well as in the community if they're doing, or someone who has recently been showing repeated visits to ER. Paramedics will notify us, can you come and intervene, even having goals of care discussions. We will navigate them to be a referral to a specialist, and also kind of decrease that frustration or mistrust in the system that they will be waiting forever because they are seeing a general internist who's having ongoing care. And with collaborating with our colleagues, we kind of say what can be done while they're waiting for you so that they know that care is being provided and that while they're doing clinic.
Or take back care.
Or take back care. And if they're not able to or unwilling to come to clinic, we always find out other ways. So either a family member advocates with us, or we if they really don't want to, we will see what other ways we can provide care to them. So we have, as I said, outreach care teams, palliative care teams have worked with us. We have had, transportation. So we have actually worked with transportation to do it, and we do home visits as our clinic does home visits as well. And the family health team has now, every time we identify a patient with high care needs who needs a family physician, the primary care practice has been expanded to intake those vulnerable population into the clinic. So the work done by the family health team in terms of expanding their practice in Ashwegan has also been very remarkable and very impressive. So where this comes down, so I think Jess and Josh, I know you guys are providing care at Dahak in Brantford, and we do have a lot of patients who kind of come in between when they're not able to go there. What we had envisioned initially was to have do a virtual consult initially with Respirology and then have patients seen at Firestone if they can. What we have seen, as we mentioned, there's a high intake of tobacco in the community, so COPD, and there's also, Jerry had informed me and educated me about this, that there's also high prevalence of interstitial lung disease, which we can't recognize clear risk factors, and it seems to be familial, where you see one person and you find out that the brothers or the sons also tend to have them. And again, they're not aware of it, they haven't had follow-up, or they haven't lost a follow-up, haven't come here. So we tried, so I think one of the things was to actually screen these patients. That was, I think, one of their priorities we identified is actually screen these patients. Even though there's a high rate of cigarette use, we find patients coming to the clinics are actually very good at listening to advice. So we do it. We do work with the traditional healers, and our nurse, Kathy, who is like amazing, will actually do that cultural translation for us to actually advise around tobacco use and cigarette smoking. And we have actually had good success with some of these patients. Again, I think the fact that we are working within the environment and respecting their values plays a long role. So I don't just again, going back to that, basing it on strengths. Like a lot of the patients who do, if you build that first contact, they do start working with you on cutting down their smoking or cutting down, their exposure to it. The screening of ILD, we either have patients not showing up even after we have either had them at, and we do give them the offer, like, we can see Josh or Jess at Dahak, and if we can make a referral there or come to Firestone or go to Brantford, and still not getting a lot of buy-in, because I think that they would like something to be done locally, and they would actually say, I will do my PFTs when they can happen locally. So we have just had to start them on inhalers and hope that one works. But we don't really know what's actually going on or get a baseline X-ray. So our vision was to actually do first a virtual consult, but then have in-person clinics. With Ganyos closing down as a building, we were reduced to one clinic, which now all the specialists share. So in terms of when I say specialist, we have GIM that works over 2 weeks a month consistently. And then we have endocrine that does one clinic half day a month, and geriatrics that does one half clinic a month. We wanted to expand this to cardiology and rest, because those are the two, based on the population, are the two highest need. And I think rest is very untreated and unscreened, and probably not as much appreciated by the community that this is a huge concern, especially when we go, like we have some ILD patients that we are following from a palliative care perspective, and you can, when they will say, oh, our son has the same thing, and they saw someone in the US and they haven't had any follow-up, and it's very hard to get that buy-in to who's screening them, who's their family physician. So we do think those are screening is a huge priority. What was offered because of the room, we not having enough room, what was offered by Helen neighbor was that with the advent of the rapid access respirology clinic, if we could have a standing virtual assessment over there for some of these patients, and consider if there was an opportunity to do an in-house spirometry to at least get some readings, and then to kind of navigate these patients, the high-risk patients to Firestone. Or DAC if they were willing to go there, but that's where we want to open the dialogue and see what everyone else thinks. So we kind of discussed this. So just wanted to, I think Curtis had brought this up, that there's a lot of risk factors. So there prematurity, low birth weight, poor nutrition. There is a lot of disparity in socioeconomic factors within the reserve or within Indigenous people that kind of also determines how they have their chronic diseases and how they trust in the system. But throughout over the last 1 year, I said it's been very gratifying on how we have kind of recognized and worked with them. And again, kind of, I can't highlight enough what Curtis had mentioned, that focusing on the strengths rather than the deficits, actually seeing, giving positive reinforcements to patients when they show up to your clinic, when they are welcoming them to your house, or to actually see them. I think all those are strengths which have built us moving to a path again on that wampum belt that we are two canoes going parallelly, but we are collaborating with each other. And I think the patients are equal partners in this, and they've done a great job in building that trust. And we're hoping that if we are co-designing them with the community is directing us in how they would like their care to be received. I think we could actually have a very successful respirology management over there.
That's just NIHB looking at which puffers were covered and which not. Do you guys know if antifibrolytics are covered by NIHB?
Yeah, we did have them covered for. And we haven't actually had any issues with having them covered, sorry. Right. So I'll leave that. This was our way of, so thank you, Marcel, for inviting us. And I know we were going to have this discussion with Helen because we were going in a stepwise process with first establishing endocrine, then geriatrics, and then opening up to rest. And I'll leave it over here for thoughts from the group and what you guys think about it, or any other questions that we may not have answered.
That's fantastic. Thank you very much. It can be overwhelming, right? For people who don't participate in or just the occasional patient who makes their way in is all you deal with. We read recommendations that you need to do cultural, education and things like that in order to even begin. That creates a barrier. So there's barriers on the end, on the First Nations end, but there's barriers on our end as well that some people don't know where to get started. So for somebody who's here, where do we get started?
Yeah, so I can say where, I knew information, again, I've heard about Truth and Reconciliation, and their barriers to health, and it was like, well, I'm going to start this clinic, how hard could it be? And I think part of it was just learning things from their values. And I think part of where to start is if you are seeing a patient. From my understanding, one of the first things I was told is you have to learn to listen to the patient. I think that was probably the most important thing, that you don't tell the patient what to do. Ask them what they want from you or what care they would receive. And that actually led to, even though that may mean, working at Stewards or working in GIM or even working in IMRAC, it's very much like, you need to get the ball rolling, and anyone was work with me, I like the ball rolling very quickly. So it's actually slowed me down by a lot of bases. So on IMRAC, we will be seeing about 20 patients a day. Over there, we see about 3 to 4 patients. So every patient has an hour to themselves. So I think the first part when I asked, how do I get started? I actually was you have to listen to our stories. Even though that, like, when I remember I did this with our GIM group, they said, well, that's what we're supposed to be doing. We're supposed to be good listeners. But it is a little different. You can't ask them to go back on track and tell them about shortness of breath. But it's about understanding where they're coming from, what they believe that their shortness of breath can get better, and get understanding what else is affecting. And with us, we are very lucky, and Kathy would work with all the specialists as well, that she kind of navigates that storytelling for us. But I think one of the things that we have addressed when we are bringing other physicians in is actually to taking the time to listen to patient stories and having that dialogue, which is where they feel, and a lot of our patients, even when we are going at home and discussing things with them, they want us to listen about how things have transitioned in their life, how the disease is affecting their lifestyle or their means to earn or to take care of their family. That's the first part of trust building. And I find after that, things start just going into place into how we manage patients naturally. But I think that's probably the most important thing I was taught over the last year. And I think that's probably the same thing that I would say when we get started.
Purposeful listening.
Yeah, purposeful.
And I would say just kind of taking the time and like doing your background reading and like building your knowledge on your own. That can be a bit scary and you don't really know where to look, like resources or literature wise. But one of the things about Indigenous communities, it's all about kind of like putting time in, and even with listening, like we're putting more time into listening, putting more time into learning about these communities and showing like how committed you are to building that relationship. It's not always about results. Like results are a very Western way to kind of think of things, like what is going to be the outcome? What is the goal of this project? Like what's the destination? For us, it's more about the journey, kind of building that kind of relationship down the river. And part of that is showing us that you're putting the time in with doing your reading and doing your background knowledge, not going into an Indigenous person being like, what can you tell me, what do I need to know? No, you come to the table with everything you've sought out and you tell us, and we will tell you whether that's right or wrong. So also listening, but also showing us that you're committed to building that relationship. I think that's a good place to start.
There's something that I know that we had talked about a while back. One of the questions from a person at a remote site is what's going on with lung cancer screening. I know that we put you in touch with Christian Finley.
So for the lung screening, we have actually started, we asked the family health team to take over that. So they are essentially starting the screening process. There is a cancer screening bus that comes to the reserve, I think once a month. They do the mammography and the flex sigmoid, and we have added the lung cancer screening to that. It already started identifying high-risk patients.
We got one.
Sorry, they have a CAT scan on the bus?
Yeah.
Yes.
So there's a big dental bus and then a big cancer screening bus.
There's a comment in the chat as well about interpretation of PFT or spirology. So it would be challenging given the lack of reference in this group. There's actually been a number of studies showing that Indigenous populations, excluding Inuit, they actually match the Caucasian numbers much better than the GLI global or any other reference equations. Many studies showing the same thing. Inuit populations, the numbers are wrong. Their lung volumes are higher for height. Just like BMI is not accurate for Inuit populations. There are differences. So there is data out there, but they're not in any of the PFT software. So the best you can do is just use the Caucasian data, which is is not ideal if you're dealing with people from everywhere.
Yeah, but to be honest with you, it's the change is often more important than one single value that's obtained. And the change is evident no matter what your predictions are. So you can take good care of people without the world's best predicted values.
Yeah, as long as the person's willing to come there more than once.
How you go to
How
them.
many
Exactly.
lung diseases to be cured in your lifetime, Gordon? Seriously.
Yeah.
They're probably still there in the future. They won't care with you.
Martin Cole made a comment that they have a few families with familial IPF, large families, and they've gotten at least 5 of them to lung transplant in the past few years. So is there a group of family doctors that we should engage, that we get, you know, do we have Indigenous family doctors in the area, or are there local clinics that we should engage with when we have people who don't have family doctors?
So I think one of the ways, if they don't have family doctors, sending the referral to our IMRAC as well from Joe's, we can actually do that. So if we see that there is no family doctor, we can provide that bridging care till they get a family doctor. What happens is we screen them, kind of ensure that their medical conditions are stable, and then they can be activated the intake process for them to go to one of the family health team pods.
Yeah, so we kind of act as that gateway, and that's kind of the point of us. So
Yeah.
like if people want, it's like a way to come back to community, and then we kind of send them off.
And I can send the referral form.
So on that issue of specialist care in different domains, have you had any resistance when you have done the initial intake, done the assessment, and said this should you be best seen in another center?
Mhm.
Have you met resistance at that time when you've had some you know, a body of information that is a conservative opinion that your illness is serious enough or complex enough to deserve travel? You've had resistance at that time.
So I can give mine and Khalid can say they are, yes, so they're, I would say it's 1/3, 1/3. So it's 1/3 is that we will have, I'm not going out of the community, care will only be provided to me in the community. So if someone wants to come here, I'm happy to see them on this thing, but you have to be with me when I get that assessment done virtually. So we do not leave the patient by themselves, either Kathy, our nurse, or we are in the room when they're having a virtual consultation being done with another specialist. So we'll have 1/3 will actually say not going out off the reserve or getting care outside. It's too much for me, or I'm not comfortable, or they have had experiences in the past that we have then others who will say they would only go to Brantford and they're happy to do it, or they will actually limit themselves to Brantford and not come to Joe's. And then we will have others who will say, yes, that makes sense. And both the other two, we will actually sometimes have this commitment that they will need from us, that you will still be involved in that care. But I don't know how tomorrow would be, where I'm not able to get to St. Joe's or Brantford. So I need to know that I still have my anchor over here to actually get care. So that's how we have found with cardiology, resp, like even surgeons, that we have to be involved in their care till they either bridge or did they actually say, yeah, I'm good, or things have been wrapped up, or they agree to, or they don't agree to. And we kind of have to navigate that.
I would
Very
agree.
interested in your lung cancer screening experience, because the next step is CT guided biopsy or PET scan, but they're not delivered locally. Let alone the other problems that are found at the time of lung screening, that are infections or interstitial lung disease or something that are probably hypertension or goodness knows what. Lymphadenopathy, you would have on your list already as a common reader referral. So again, investigation of those typically require a specialist center. So it's interesting to hear how that dialogue works out.
So for the lung cancer, I can tell you that we, again, Christian has been very kind and kind of navigating that for us, and that because he will see the patient in Bradford as well. So he has been able to help us with, where the patient needs wants the biopsy done. So we haven't had any resistance to that. If a cancer is metastatic, or the patient says, I'm taking my chances of dying, but I'm not going anywhere, we have then helped them with that transition to care as well. But with the biopsy, we have had 2, I'm sure Khalid has that many. We have not had any issues with having them to go to a center. The issue has been more with oncology, where a patient, again, exercising right to self-determination, says, I do not want to get treatment at Brantford, or I do not want to get treatment at JCC. I want to go to another center. But because we do have Indigenous navigators at the cancer center, they've helped us navigate that even though, by the Ontario Ministry, we would have to say that this is your catchment area, you have to go there. But if the patient says, no, I don't want to go there because of so and so, our navigators have actually helped us navigate that to get them to where they would want to.
And more of our patients, I will say, prefer to go to Brantford than Hamilton. And one of the reasons for that is they have an inpatient Aboriginal Health Services team, where any patient who is admitted and identifies as Indigenous is followed by like a kind of like an Indigenous healthcare team that provides traditional healing, purposeful listening, things like that. So patients prefer to go there than the Hamilton centers just because they feel like the care is more culturally safe.
The other thing that I will say with the medical transport, we have done so with the patient that Kieran had seen for us for ILD. We actually organized all their testing the same day. So we got the transport team to take them in the morning, and we just had everything organized, you know, their PFT, the CT scan, everything, and Kieran saw them at 2 p.m. And so we had, so that's another thing that why Imrak Clinic is a little works better, that it will be hard for the primary care team to understand that logistic, that it's not easy for them to go and book all these transports. So we try to do it, and we will actually, and if a patient cannot mobilize because of disabilities, then we actually get the paramedics team to actually help. So some of the patients needing oxygen and stuff, we will or cannot get down the stairs from their house, we will actually get the paramedics team to help us, which would actually cost us quite a lot if we were to use any private patient transport.
Albina?
So that's a great thing where we actually, there is a plans to get an RT in the community with the primary care team. Right now, I think the closest RT that they have available to them is in Simcoe. But there are plans to actually have it as part of the home and community care to have respiratory therapists on site.
My question was actually on something that's, it sounded like, forgive me, because I'm a patient science, I'm a patient, so what do I, but it sounds like when you're listening, like occupational therapy could also be person-centered, modifying the environment to needs of people, but also be really important. Is that part of your team?
I think the family healthcare team has an OT that works with them, not part of our GIM team, but it's more with the family doctors. I would say the one nice part about our setup is, like Zahira was saying, we work like right beside the family doctors. So all day it's kind of back and forth between our patients, which also contributes to kind of the shared care health model. But the family doctors will usually arrange that as well with like community services. Our nurses also will arrange this, like we mentioned Kathy quite a few times, like when she's telling us about the patient, she'll be like, I've already arranged community OT and community PT before it's even gotten to us. So they know a lot about the in-community services, and they navigate that so well, much better than we could.
Yeah, so we have two OTs who work with at home. They are very, very overstretched. And I think the physiotherapists also, we do not have, I think, more than 3. The paramedics actually help with a lot of home supports, and then we will have some stuff if we get advice that we will get from home and from Lynn. So there's home and community care, 6 Nations, and then Lynn home care. So we sometimes have to depend on Lynn home care to do it, which is where a barrier exists. But the community itself does have 2 residential OTs who will actually help with the care, especially with respiration. So our paramedics will actually even go and give at home nebulizers if they want to. Sometimes they're patient want
You put a question mark beside on-site access to spirometry. I know that was something that we had talked about very early on about getting a spirometer and getting things done there. What happened?
So I think Helen is making that as part of rolling out the rapid access clinic. I think we do, so the budget that Jennifer Smith, who's the executive director, that is part of our budget as well. So we get a spirometry. We have, and I think a lot of it happened is when we didn't have access to the procedure room anymore. So the issue there was the space. So initially, but now I think part of our moving towards our rapid access clinic was to actually then have on access site. So there is funding available. We just have to figure out the working and who, how we will actually roll that.
Just thinking about 2 different things in terms of testing and being able to bring it on locally. My first question was, who's funding the mobile CAT scan? And if so, is it also available for non-malignant conditions in terms of the screening, or is it specifically only for lung cancer? That was my first question. And so, and obviously from a very biased perspective, I'm looking at screening for ILD because that's better than any CT or DLCO that you measure on site. CAT scan is probably the best test for that. And the second question is have you considered reaching out to pharma partners, potentially getting access to on-site pheno as a point of care testing that could be running down for identifying patients with underlying airways disease that may be responsible to more targeted therapies?
I can answer the first question. But no, right now the cancer screening is by Ontario Cancer Screening Program. There is funding for a mobile medicine unit that Jennifer is going to be placing in the near future, that they have been approved for funding. So we can, Curtis and I can bring it up to her if we can. We have a mobile CT scan approved not just for cancer screening but for ILD, because we have identified to her that this is high need getting to a CT scan can sometimes be a barrier. So we can definitely bring that. So that's a great idea. I would have to be educated about the pharma and the pheno. So we can definitely kind of take that offline and discuss that. But we would be open to that if we have discussed that. But I know the CT scan is Jennifer does want us to come back to her and let us know what we can put in the mobile unit. So she will definitely be open to that.
Albina? That's $2,000. Yeah. But then there's consumables for each procedure. So you need to do this was a few years ago, you needed to do about 200 to 250 spirometries for the billings to have fully paid for the equipment. So if you have the numbers, then it's fine. You might not quite have the numbers, very quickly in this sort of setting.
Mm-hmm.
So then the funding has to come from outside.
The cost of it is modest, the billion operating is the other thing. So the training of somebody who does this function, part of the controls and another issue. So but Sarah knows more about this than any of us meeting. So
The cost is relevant, yeah, if you do enough.
All right, one last question.
Did a dedicated training just for spirometry, had our own device. We also work with a population that was challenging to get to specialist appointments. And she just did it on site. Of course, what the challenge is making sure that you're doing enough to ensure that you're having accurate assessments. But I think it's a great investment. You're able to definitely on site.
So cool.
Fantastic. I really appreciate you coming to speak to us about this today. This was fantastic. And everyone, I would encourage you to approach them if you want to get involved in any way. They are very approachable, very enthusiastic, very driven kind of people. Email, call them, come up to the front after the